Hello, everyone. My name is Li-Tal Pratt. I'm a pediatric radiologist and neuroradiologist in Tel Aviv Medical Center in Israel. I would like to thank Felice for the opportunity to share the presentation I gave recently in the annual meeting of the European Society of Pediatric Radiology. I will be talking about pediatric MOG-associated disease. The spectrum of acquired demyelinating syndromes has dramatically evolved over the past 2 decades. The first and well-known pediatric entity has been multiple sclerosis. The discovery of specific autoantibodies targeted against proteins in the central nervous system allowed recognition of distinct inflammatory demyelinating conditions. In 2004, the identification of aquaporin 4 antibodies has led to recognizing seropositive neuromyelitis optica spectrum disorder, or aquaporin 4 NMOSD, in patients previously labeled as optico-spinal MS, and later on with the identification of autoantibodies against myelin oligodendrocyte glycoprotein, or MOG antibodies, as a biomarker in a broad spectrum of demyelinating and encephaliting conditions, altogether termed MOG antibody-associated disease, or MOGAD, with predilection for the pediatric population and with diverse imaging phenotypes. There are also unclassified patients with seronegative disease that can exhibit both monophasing and relapsing demyelinating events. And there is a broad differential diagnosis of conditions mimicking acute demyelinating attacks. In 2023, the International MOGAD panel established formal consensus criteria for diagnosis of MOGAD as a distinct entity. Imaging plays a key component in the proposed criteria and is essential for diagnosis as well as for follow-up of MOGAD patients, as in recent years there is a growing evidence of unique lesion dynamics during and post-MOGAD attacks that are distinct from other demyelinating conditions. During this talk, I will discuss the various MRI appearances of pediatric MOGAD at presentation of disease and during surveillance, in light of the new proposed diagnostic criteria and in comparison with MS, aquaporin 4 NMOSD, with a few examples of the differential diagnosis. Before we move on, I would like to show you 4 cases. 2 were eventually diagnosed with demyelinating syndromes and 2 are mimickers. And I would like you to have a look at the images and try to assess which one is compatible with demyelinating disease and which one is a mimicker. Patient A, here on the left, was a teenager that presented with acute diplopia, dysarthria, and left side paresthesias. On the axial T2 image, there is an ill-defined hyperintensity infiltrating and expanding the pons with involvement of the right middle cerebellar peduncle and mass effect on the adjacent fourth ventricle. Patient B on the right was a young girl that presented with encephalopathy and vomiting. On this axial T2 image, there is an abnormal ill-defined hyperintensity with thickening of the ventral pons. Patient C, also a young girl that presented with similar symptoms of encephalopathy and vomiting. On the sagittal T2 image, there is a longitudinal extensive hyperintensity involving and expanding the cervical cord and medulla, specifically the region of the era postrema. And patient D, a teenager boy that was hospitalized with an acute onset of spinal symptoms. On the sagittal T2 image here, there is a long anterior hyperintensity along the middle thoracic cord, similar findings on the axial images with predominant anterior involvement or the so-called snake eyes pattern. 4 months after the acute event, he was referred to our demyelination disease clinic with presumed diagnosis of transverse myelitis. And we will get back to these patients as we go along. There is a wide variety of clinical MRI phenotypes associated with MOGAD. The initially described patterns included ADEM, optic neuritis, and transverse myelitis. This can occur separately or in combination, altogether comprising more than 90% of pediatric MOGAD presentations. Included here are also children with MOG seropositive NMOSD-like phenotype that can present with simultaneous or sequential optic neuritis and transverse myelitis. The MOGAD phenotype is age-dependent, which might reflect variability in MOG expression at different age groups. Young children less than 11 years of age tend to present with ADEM phenotype, while older patients present more commonly with optic neuritis. Over the last decade, the MOGAD umbrella has been continuously expanding to include other unique clinical or radiological brain patterns that are not compatible with the definition of ADEM. These are listed here. Recent publications have shown that autoimmune cortical encephalitis is more prevalent in children with MOGAD than previously thought, so I moved it upward. And the leukodystrophy-like pattern mentioned here is considered an ADEM-like manifestation in very young patients. The MOGAD diagnostic criteria that were published last year and still need validation require detection of MOG antibodies and presentation of a core clinical demyelinating event with exclusion of other explanatory diagnoses. In cases with equivocal MOG seropositivity results, the diagnostic criteria rely on one or more supporting clinical and MRI features that are common or unique to MOGAD, and this can be divided into brain manifestations, transverse myelitis, and optic neuritis, and we will now look into each one of them. MOGAD ADEM accounts for at least 50% of pediatric ADEM. Here are MRI images taken from 4 different children presenting with MOGAD ADEM, showing varying appearances of characteristic findings with bilateral, asymmetric, confluent, and poorly demarcated hyperintensities distributed asymmetrically within the white matter. There is typical involvement of the basal ganglia, most often the thalami. Other findings that can be seen and are not shown on these images are nodular enhancement and uncommonly seen diffusion restriction sometimes may be observed. And I would like to point out that in most circumstances, the imaging and also the clinical features of ADEM are similar between patients with MOGAD and patients with seronegative disease. We cannot differentiate between MOGAD ADEM and seronegative ADEM based on routine imaging alone. Younger patients less than 5 years with ADEM phenotype tend to present with larger lesions, including tumefactive lesions. They also tend to have a wider distribution of lesions, including seldom involvement of the corpus callosum, as can be seen on this mid-sagittal T2 image here. The leukodystrophy-like pattern I mentioned is rarely observed, particularly, as I said, in very young patients presenting with MOGAD ADEM. On imaging, there are extensive T2 hyperintensities in the cerebral white matter, usually symmetric changes and associated with abnormal nodular enhancement. Despite resolution of lesions over time, this phenotype is associated with poor outcome. Involvement of infratentorial structures is often associated with MOGAD ADEM or with other MOGAD phenotypes, such as transverse myelitis or optic neuritis, but rarely can occur in isolation. This is patient A that had an enhancing infiltrating lesion centered in the pons with mass effect on the adjacent structures. She underwent an extensive workup with a presumed diagnosis of a brainstem glioma. Then her MOG antibodies testing came back positive, and she has markedly improved with treatment. Her scans showed interval improvement as well, with decrease in size of the pontine lesion and resolution of enhancement. And this is a case of MOGAD Adam-like changes in the cerebellar hemispheres with involvement of the middle cerebellar peduncles and associated nodular enhancement. The presence of brainstem lesions that are accompanied by large, ill-defined uni or bilateral middle cerebellar peduncle lesions is a distinguishing feature of MOGAD compared to aquaporin 4 NMOSD and MS. Cortical encephalitis in MOGAD patients or flames is commonly associated with fever, headaches, and seizures. The typical pattern is of flare cortical hyperintensity that can be associated with leptomeningeal enhancement, as can be seen on these images here involving the right cerebral cortex. The lesions may be uni or bilateral, diffuse or focal. They may involve the juxtacortical white matter and can be associated with diffusion restriction, which is not the case here. Two other patterns have been described: the basal ganglia encephalitis with bilateral abnormal signal that is isolated to the deep gray nuclei, and meningeal involvement with leptomeningeal enhancement that may be seen at presentation of MOGAD even without evidence of demyelination or may precede demyelination and is considered a specific finding of MOGAD compared to aquaporin 4 NMOSD and MS. With MOGAD optic neuritis, we expect to see bilateral involvement of the optic nerves, on the case here more pronounced on the right side, with longitudinal extensive involvement of the optic nerve, which means more than 50% of the length of the nerve, mostly affecting the anterior segments with optic nerve T2 hyperintensity, abnormal enhancement, and perineural enhancement, which is a highly specific MOGAD feature. The typical spinal involvement in MOGAD is characterized by longitudinally extensive transverse myelitis, that is a lesion extending along 3 or more vertebral segments with conus involvement, again, a specific feature of MOGAD. Shorter lesions may coexist, and most patients have at least 2 separate lesions. On axial sequences, there are 3 main patterns: central involvement with H sign here on the top image. On the middle image, hazy involvement of most of the cross-sectional area. And on this image, you can see anterior horns hyperintensity, or the so-called snake eyes pattern. Associated enhancement can be seen in some cases. 3 patterns have been described. Diffuse roots enhancement, as can be seen on these axial images here at cervical level and surrounding the conus. Patchy intramedullary enhancement here along the upper cord, and leptomeningeal enhancement on this right-sided image surrounding the conus. This is a summary of the supporting MRI findings included in the diagnostic criteria from left to right: Adam-like changes involving the supratentorial white matter and deep gray matter, infratentorial involvement here with typical involvement of the middle cerebellar peduncles, and cortical lesion. Optic neuritis with bilateral longitudinal T2 hyperintensity here, and on the middle image associated with abnormal enhancement and perineural enhancement, and on the right image, enhancement and swelling of the bilateral optic nerve heads. And spinal cord involvement, including longitudinal extensive transverse myelitis, central cord and H sign on the axial images, and conal involvement. The timing of imaging is crucial in MOGAD, with different appearances according to the disease stage, acute, follow-up, or relapse. Clinical signs and MRI findings can evolve and fluctuate during disease attack. This phenomenon is regarded as radiological lag of disease and does not reflect a relapse. Therefore, establishing an accurate phenotypic diagnosis may be challenging during the initial presentation period. In addition, MRI scans can be normal at presentation of disease, as have been reported in up to 10% of brain and spinal cord attacks. So if clinical signs persist, a repeat MRI scan within several days is recommended. And this image was taken from a paper that was published last month that assessed intra-attack lesion dynamics in pediatric MOGAD compared to MS and NMOSD. MOGAD patients often develop multiple and new ill-defined T2 lesions at second intra-attack study compared to MRI stability in about 75% of patients with MS and aquaporin 4 NMOSD. Post-attack resolution of clinical symptoms and radiological T2 lesions is expected in approximately 70% of MOGAD patients, and lesion resolution over time is also unique to MOGAD compared to aquaporin 4 NMOSD and MS. Early treatment with steroids and/or plasma exchange improves T2 lesion resolution. Interval appearance of new silent lesions has been uncommonly reported in brain scans of children with MOGAD, often within the first months after onset of disease. Several studies reported a low positive predictive value for relapsing disease with this type of lesions, but others suggested that this actually may herald an impending relapse. And this is a 2-year-old boy presented after a viral illness with a focal seizure on his first MRI on the left image here. There were very subtle flare subcortical hyperintensities. Then after 4 weeks, he presented with progressive clinical deterioration. A repeat MRI showed characteristic findings of ADEM this time, with extensive confluent abnormal signal changes involving asymmetrically the white matter, basal ganglia, and thalami. And this time, the kid was found to be MOG seropositive. He improved markedly with treatment. On his first follow-up imaging, there was a dramatic near complete resolution of the T2 or flare lesions. But on a follow-up study 20 months after the initial attack, there was a new flare hyperintensity involving the left parietal white matter with abnormal nodular enhancement. The kid was asymptomatic at this time, and on his next follow-up, the lesion resolved. So this case shows several characteristic findings of MOGAD dynamics. The first 2 scans demonstrate the typical radiological lag or fluctuation of lesions, which does not reflect a relapse of disease. The second characteristic feature is interval resolution of lesions between disease attacks. And silent lesions appearing on a routine follow-up of patients are uncommon and are not considered a relapse of disease in clinically asymptomatic patients. Most pediatric MOGAD presentations are monophasic. However, 20 to 30% of children may exhibit a relapsing disease. No radiological features at onset have been associated with risk of relapse, but worsening of imaging with new lesions appearing on first follow-up MRI is a predictor of relapse. The clinical MRI phenotypes at relapse are also age-dependent and may differ from the phenotype at initial presentation. We have to keep in mind the possibility of differential diagnosis of MOGAD, which includes MS, aquaporin 4 NMOSD, and a broad list of other mimicking conditions. I will show you just 3 examples. This is patient C, who had longitudinal extensive transverse myelitis involving the cervical and upper thoracic cord, with involvement also of the medulla and the region of the era postrema. And on axial images, the abnormal signal involves the central gray matter and surrounding white matter almost looks like a pocket of CSF. That's called bright spotty lesion, which is characteristic for aquaporin 4 and MOSD. She had no corneal involvement, making MOGAD less likely. And on the brain, she had a single posterior periventricular lesion. She was seropositive for aquaporin 4 antibodies and was diagnosed with aquaporin 4 and MOSD. Patient B that had an abnormal ill-defined T2 hyperintensity with thickening of the ventral pons, unfortunately had extensive leptomeningeal and nodular enhancement along her spinal cord and was diagnosed with high-grade metastatic glioma. And patient D that came for neurological assessment 4 months after an acute presentation of transverse myelitis. On his first imaging, he had longitudinal anterior involving along the middle thoracic cord. On follow-up, there has been an interval thinning of the cord with the resolution of the abnormal signal. Extensive workup was negative, including seronegativity to MOG and aquaporin 4 antibodies. And on the sagittal T2 image, there was a reduced height of the T5 to T6 intervertebral disc with T2 signal loss. So we raised the possibility of cord infarction due to fibrocartilaginous embolism. This presumed diagnosis was also supported by the acute onset of complaints. To summarize, the phenotypic spectrum of MOGAD is broad, with continuous recognition of new associated radiological patterns. These are age-related and reflect myelin biology under the age of 2. When myelin is still forming, we get the leukodystrophy-like pattern. Then during myelin formation, initially ADEM, then cortical encephalitis. And when myelin is compacted in teenagers and adults, we see more often transverse myelitis and optic neuritis. Imaging has an essential role in the recently published international MOGAD criteria, and the radiologist should be familiar with the described supporting imaging features. MOGAD has been increasingly recognized as a dynamic disease with intra and post-attack evolution of lesions appearing and disappearing, which is a highly discriminating feature from multiple sclerosis and aquaporin 4 and MOSD. Remember that initial MRI may be normal in up to 10% of spine and brain studies at initial attacks, so this might be a caveat to the newly diagnostic criteria. Awareness of such a possibility should prompt a repeat scan if clinical symptoms persist. We acquire a follow-up MRI scan 3 months after initial attack as a new baseline and for assessment of radiological leg features. Currently, the diagnosis of relapsing MOGAD is restricted to patients with clinically relapsing disease and is not based on imaging alone. Considering the rarity of interval new lesions, the value of routine MRI surveillance is questionable, but we do recommend to do a follow-up MRI every 6 months for patients with relapsing disease on maintenance therapy. And this is a chart summarizing the main clinical MRI patterns of MOGAD as compared with aquaporin 4 and MOSD and MS. Keep in mind the mimickers. And thank you for listening. This is my email. I would be happy to receive questions, comments, and opportunities for collaboration. Thank you.